Hello, and welcome to Bone Up, the podcast all about bones, how we make them, why we break them, and if we fully understand them. I'm David Armstrong.
Hi, and I'm Richie Abel. And over this series, we're going to be exploring osteoporosis, bones, what we know and what we're yet to discover. And we hope you will join us on the journey.
So, for anyone keen to learn more about our infrastructure of calcified collagen, this is Bone Up. Hello, and welcome to another episode of Bone Up. I was going to describe this as the high summer episode, Richie, but I don't know if we really have high summer any longer in the UK. We sort of have rain that's a bit warmer for a few weeks, and then we're into autumn. But welcome to the high summer episode anyway. You've been away anywhere nice?
Yes, managed to go on a short holiday with the family to Spain to escape the tragic summer in Britain right now. I think everybody could do with some sun just to cheer everybody up a bit. It's about time.
Yeah,
What
that
have
was
you
nice.
been up to this summer?
Yeah, my wife and I were in Haarlem, actually. That's the Netherlands, Haarlem. And we've been to the Netherlands before, but never to Haarlem. And it was a lovely place. And actually, we got really good weather. So it's nice to get a break and get away from work. Although I must admit, I did bring a paper on macrophage contribution to osteoporosis development with me to read because I've been meaning to read it for months. And I read it on the plane. And I was the only person on the plane reading about macrophage function in osteoporosis, I think. Um, but after that, yeah, it was good to get a break and back refreshed and ready for more bone health.
There you go, listeners. Medicine is a way of life, not a job. So it might come in handy that you've read that paper, given today's topic. So, listeners, on the show, we've talked a lot about bisphosphonate and romosozumab treatments, but a few of you have got in touch to say that we haven't really spoken much about another important treatment, which is denosumab. I was wondering, David, if you'd be able to explain to us your clinical uses for denosumab.
Yeah, well, denosumab or Prolia, as it's probably still widely called, is at its simplest is simply another drug for osteoporosis. It's a 6 monthly injection, which generally in the UK is administered by the nurse and administered in primary care, although oversight is from secondary care from your consultant. Um, it works on the side of the fence, you might say, preventing bone loss. So, do you remember the very first episode we did of the podcast, Richie? I used the metaphor of the bath, and we're trying to fill the bath up with water. And you can either turn the tap on faster to get more water into the bath, or you can put a plug into the plug hole to stop losing water. So denosumab is on the plug hole side, if you'd want to say. It reduces bone loss, um, but it works differently from bisphosphonate. It has advantages over bisphosphonate in that the mode of onset or the actual speed of onset is quicker. You can use it in patients who have renal impairment and, in fact, even end-stage renal failure. And it's not orally administered, so it's very useful in patients who have GI side effects with bisphosphonates. It's been available now for over 10 years. And I think it's probably fair to say, like many drugs, when it came out at first, we sort of rushed to use it for lots and lots of patients. And then we discovered lots of good things about it. And then there were sort of issues around where we had to think more carefully. And its use has probably reduced a little, I would say, in the last few years. Um, but we're sort of getting more of a handle now on exactly when it should be used and where it should be used and how long it should be used for as well, which is important.
So you're saying then that it's a drug that's been in use for a long time, seems to work more quickly than bisphosphonates, at least at the beginning, and it seems to be better in terms of side effects. So why don't you just give it to everyone all the time?
Yeah, that's a good question. One of the issues with bisphosphonates, as I think most people who have any insight into osteoporosis will know that um, you cannot use them indefinitely. You have to have what's called a drug holiday. And that's because reducing the action of osteoclasts, reducing bone loss, is good for the bone in the short term. But if you do that in the very long term, then you run into problems with almost switching bone turnover off completely. And you run the risk of these very rare side effects like atypical femoral fracture. And those exist with denosumab as well. Whereas with bisphosphonate, you can simply have a drug holiday, and the levels of bisphosphonate in the bone will go down very slowly, and you may have what you call a soft landing. In other words, bone turnover will quite slowly start to rise again, and you can control that. With denosumab, when you consider a drug holiday, bone turnover rises very rapidly, and the patient can lose bone again very rapidly and can run into risks of increased risk of fracture during that period. So one of the things I think we've discovered in the last 10 years or so of using denosumab is that you need to plan carefully at the start of the treatment how you're going to get the patient off the drug again. And that may be after 5 years, it may be after 10 years. Of course, there will be patients you may decide to stay on the drug indefinitely, but then that involves a careful discussion of the risks and balances with the patient, and trying to give the patient, the sort of the scientific background to how that works and the evidence about how it works, but also explaining to the patient, I think, that there are gaps in the evidence and that there are areas in the long-term use of denosumab where we simply have to say the research hasn't been done yet. So it's a very useful drug, but there are challenges with its use. And certainly, once you start the drug, you can't just stop it again without using something else. So you need to think in the long term. And again, that involves, just building up a relationship with the patient and trust with the patient, and explaining and trying to interpret data, and interpret these difficult issues about risk and so on, to the patient. And that's something we've obviously covered before. And the exciting thing about denosumab is it can be used in a much greater range of patients than bisphosphonate, which is good, and it works in a different way. It works on what's called the rank and rank ligand sort of pathway. Um, I'm always encouraged at how interested patients are at how their drug works, and always surprised sometimes how deep discussions I end up getting into with patients, even at the clinic, about exactly how their bones work, how the cells respond to medication. I think the more information patients have, the more likely they are to take a drug and comply, or at least the more likely they are to make a decision that they are happy with in the long term. So, I mean, one of the things I'm always interested to hear how you explain these quite complex scientific issues, because I think it's something you're very good at. So, tell me about rank and rank ligand, then, Richie, and how I can explain that to patients in terms of how their cells work.
That is a good question, and it's a topic that I've covered quite a bit in teaching. So, denosumab then is a medicine that acts on the bone cells which maintain our bone mass. Many listeners will know we're talking about the osteoclasts, which resorb old bone, and the osteoblasts, which form new healthy bone. And basically, denosumab works by preventing the osteoclasts from resorbing bone. Denosumab exerts its effects on osteoclasts via this physiological pathway, the Rankel pathway. And it's a very interesting pathway in bone, this, and very fundamental. And essentially, what happens is the osteoblasts release a protein which we call rank. And rank travels to the osteoclasts and binds to receptors on the osteoclast cell surfaces. And this triggers a reaction in the osteoclasts. Primarily, what it does is it encourages immature osteoclasts to mature into mature osteoclasts and begin to start resorbing bone. So think about the baby osteoclasts turning into adult osteoclasts and beginning their work. And denosumab works by blocking this pathway. It acts as a decoy for this rank protein. Denosumab binds to the rank protein and inactivates it. And therefore, the osteoblasts cannot upregulate the osteoclastic activity, and that slows and stops the resorption of bone. And denosumab is a very interesting drug. It actually works by mimicking naturally occurring proteins in our body called osteoprotegerin, which would normally carry out this decoy job. It's really good that scientists have been able to study this rankle-rank pathway and the regulation by osteoprotegerin, and then create a drug which mimics its action. It's really a really great example of how basic science is translated into clinical science, and not just within osteoporosis, but across many chronic diseases.
Yeah, that's an excellent explanation. And as you say, it's a very good example of how understanding how the body works has enabled us to design very specific drugs. One of the big differences, probably from the bisphosphonates and from denosumab, is of course that bisphosphonates stick to the surface of the bone and stay there for a long time, whereas denosumab really doesn't adhere to the bone in any way. It has its effect and then it sort of disappears from the system. And there are many ways in which that's advantageous, and there are other ways in which that's sort of disadvantageous for people. But like many things, there's still lots to discover and lots to learn here, isn't that right?
Yeah, yeah, and it makes me wonder actually. The last two episodes that we did from the ECTS conference, what guests we interviewed who are studying a physiological pathway which will result in new treatments in the future. It'll be a long time before we find out, but listeners, we can tell you that we brought it to you first.
One of the big areas that we want to know more about, I think, in the use of denosumab is what we do in the longer term. What do we do when you have been on this drug? And while we don't have all the answers for that, we were able to speak to someone who was attending the ECTS conference, but who kindly agreed to join us for a full length episode of the podcast, who is doing research specifically in this area, very exciting and interesting clinical research, and something that's very relevant to day practice. We're delighted to have with us now a longtime friend of the podcast, I think, enthusiastic supporter, Elena Tsourdi. Thank you for taking time to speak to us. We're very excited to hear what you have to say. We're here actually in Marseille at the Congress at the moment, so are you enjoying yourself?
I'm enjoying it very much. Thank you, David. Thank you, Richie, for inviting me. And I'm really looking forward to talking to you about
thank you for joining us.
osteoporosis and all.
Gave a talk yesterday at ECTS about treatment targets for osteoporosis medications.
Yes.
What did you tell the learned audience?
First of all, I enjoyed very much that it was very interactive. I tried to do it so. I tried to give some food for thought, and also people bringing their own cases. So the particular subject was what target to reach in order to discontinue osteoporosis treatment. And of course, it is a subject that has been very widely discussed the last years, I would say. I based it more on bisphosphonates, but of course, as you know, it's also a very big issue regarding denosumab and its discontinuation. Of course, given like the different particularities of bisphosphonates with their long-lasting use, and the fact that after you discontinue them, you don't have this massive overshoot of bone turnover and the loss of bone mass that you have with denosumab. There are different strategies of going about it. So, especially pertaining bisphosphonates, I think it's very difficult to pinpoint it to a specific T-score or BMD target. It should be rather individualized. You should take into account a lot of aspects. Some are mostly inherent to bisphosphonates, because not all bisphosphonates, of course, are created equal. You have others with greater affinity to hydroxyapatite, as for example sol, others with less so. So this is one aspect to consider. And of course, patient adherence, because especially this is notoriously very low when it comes to oral bisphosphonates. So you cannot be sure where you say, okay, this person has been on oral bisphosphonates for 3 to 5 years. You cannot be absolutely sure that they have been taking them also. There are ways of checking it, like with doing bone turnover markers, bone suppression markers, in order to get an idea if they are compliant. And then again, there are also aspects which are inherent to these patients per se. So other risk factors, other diseases, other concomitant medication that they might have. So it's quite complex, and it was also what came out of the discussion, that it's very, very difficult to pinpoint it to a specific BMD or T-score target.
What I see in clinical practice maybe a few years ago, lots of patients were going on to bisphosphonate and staying on it for a long, long time, and we were running into problems with atypical fractures with some people. And the message, I think, got out there very strongly, both to general practice and to patients, that we should be considering holidays or treatment pauses. I sometimes think now the pendulum has almost swung the other way, where I see patients taking bisphosphonates maybe only for 3 or 4 years and then stopping, and I think that patient should really have stayed on for longer. And I also find there's a message we need to get out there, that it's okay to restart the bisphosphonate, because lots of people are stopping it and never going back onto it. Where do you feel all that fits in? Where do you think the message is at in your clinical experience? Are you worried about too many people stopping, too many people staying on for too long? What's your...
Yeah, I agree with what you're saying, and I think it has provoked also an overreaction about stopping bisphosphonates too soon, or as you say, being very reluctant to start them again. And I think there's very little evidence also on how long this drug holiday should be, or how exactly you monitor this. Should you monitor it with consecutive DEXA measurements? Probably you should monitoring with also the clinical aspects of the patients, and if the risk for fracture increases during that time.
And what about bone turnover markers?
Bone
is that, if they're
turnover
available,
markers,
is that
yes.
useful, do you think, during a drug holiday?
Where they're certainly useful during a drug holiday, with not the drug holiday, but in the concept of denosumab and its discontinuation. I think for bisphosphonates, it's a bit more difficult, because there's not really a cutoff, as there has been issued for denosumab. So which cutoff is then the one that when you go above that, you would restart them again? And
most osteoporosis is managed by GPs in primary care, and I find, when I'm advising that there's a drug holiday, I will often say to the GP, would you repeat the DEXA scan in 2 to 3 years to see what's happening? If the patient has a fracture during the drug holiday, then certainly let me know. The bone turnover markers might be a quicker and easier thing to do, but they're not available in primary care. They can only be done in the hospital. So we end up using DEXA scanning, which is a radiological investigation, but the GP can arrange that and probably knows how to interpret that. Whereas the bone marker, which is a simple blood test, it's harder to interpret, and it's only done in the hospital. So we don't use that, interestingly. We do a more complicated test.
Yeah, I agree. There's also like aspects of pre-analytic and also analytic aspects of bone turnover markers, and also other limitations, for example, patients with renal disease or where they would not be so helpful. And as you say, of course, the one thing is to order them, the other thing is knowing to interpret them. Yes, I agree,
You mentioned earlier on that potentially the best way to approach this was to provide some kind of individualised care for the patients.
Yes.
In practice, how does that work when you're a busy doctor and you've got lots of patients? Are there hints and tips that you gave people for achieving it?
So I think I'm quite fortunate to also work in a specialized center and treat primarily patients with osteoporosis, also secondary osteoporosis or rare bone diseases. So for me, I think it's really part of what I do and in my everyday life. I think talking to the patient and also this patient informed consent is very, very important nowadays, where you have all these media and also patient fora where they really get sometimes information which is incorrect, or people really pinpoint the rare adverse effects or side effects, and there's a lot of misinformation, I think, regarding bisphosphonates, but also other osteoporosis drugs. So I think this is very, very important, and I make sure to take a long time also to relativize.
Talking about
Yes.
recently. People go straight to the internet and don't always get the most reliable information, or get a lot of pseudoscience that sounds
Yes.
quite convincing, but actually if you peel back, a lot of it is nonsense, particularly with bisphosphonates.
It's one of the reasons why we started the podcast, to try and give
Yes.
you, the clinicians, a direct line to the patients and back again, so that we can build a bit of trust and try and make sure that there's quality information available to everyone.
Yes, and I think it's a great endeavor, and also to
Yeah.
cover so many facets of bone disease.
It's nice of you to pay us a compliment. I'm just going to ask you the hard question now about
Okay.
denosumab.
Yes.
And we have many listeners in all sorts of different backgrounds. So just to say, denosumab, it's a great drug for osteoporosis. You build a lot of bone, but when you stop the drug, then you lose the bone quite rapidly. And the concern is actually that you get a rebound, increased fracture risk, unlike bisphosphonates, where when you stop the drug, you get a very gradual letting down.
Yes.
And there's a lot of debate at the moment as to if you stop denosumab, when you stop denosumab, and what you do when you stop denosumab. So I might just throw that up in the air. I'll throw that ball up in the air and let you serve it, because we know we've got a great interest in tennis. We'll talk about it later.
Indeed, I do, yes. So, yeah. Denosumab discontinuation, it is, of course, the subject of the day, as you said. Yeah, it is, again, an individual approach to each patient when you would, and if you would consider, of course, to discontinue it. In order to come into this discussion of, in the first place, also we have to consider when to start it. It was something that we also discussed before. So I think there has been maybe a trend shift of starting denosumab in patients which have more severe osteoporosis or vertebral fractures, or high-risk patients for vertebral fractures or other fragility fractures. So this is one thing to consider, and also, of course, if they're very young patients, because then you could come into this conundrum of having to treat them for 30, 40 years, which, of course, there is no data at all what happens.
And you would worry about long-term
and then you would indeed
bone
worry
turnover.
about adenamic bone disease and low bone turnover. So for patients that have been on it for the, if I may say so, for the correct reasons, one option would be, of course, to continue it, and we have a lot of patients where we continue it even over the 10 years. So another thing is that there is no magical number of 10 years. This is, yes.
And let me just, so you say you continued over 10 years, and that's because the disadvantages of stopping it are greater than the advantages of continuing it. And that comes back to personalised care, doesn't it? So you're not just, it's not just one size fits all.
Yes.
You're saying, for my individual patient here, if we stop it for good reasons, the risk of you having a fracture is going to be so high, you're better
Yeah.
to stay on it.
Yes,
Yeah.
yes, and indeed, this is also what you were saying beforehand about information and misinformation. I have a lot of patients and who come and say, "Oh no, you cannot give it after 10 years." But this is just like because the longest series of published
Exactly,
data
yeah.
pertain 10 years. Not that there is one magical number of 10 years and something awful happens afterwards. So one option would be that. Another option, and this was also something which we issued in the ECTS position papers, which I was very fortunate to lead, was that if the patient is really low risk, if he has attained T-score, there are some data that a HIP T-score of above minus 1.5 could be a target to aim for, that you could then not discontinue it without any kind of follow-up, of course, but you could use bisphosphonates, especially IV Zol, to kind of mitigate this
sort of
overshoot.
gentle, letting them down
Yes,
gently.
yes.
Okay.
So, of course, there's a lot of discussion and also studies going on, which is the optimal regimen of this add-on bisphosphonates. And, of course, there are also challenges with that because some patients have had like a negative experience with IV bisphosphonates, or there are some other characteristics like renal kidney insufficiency where you cannot do it anyway. So it is a really, really individual.
I remember we chatted about this briefly with Qasim Javed last year, and I think we got around to saying there's almost a illogical concept that you give denosumab for a long time and the bone turnover is really low, and then you stop it because you're worried about the bone turnover being so low. So what do? Instead, you give a bisphosphonate with the intention
keep it low.
of keeping the bone
Yes.
turnover low, but it's not just as good at keeping it low.
Yes.
And then you think, well, where's the logic in that?
Yes.
So which brings me around to saying, why don't you just half the dose of the denosumab, or why
Yeah.
don't you just give it a little less frequently? Would that be just as effective, do you
Yeah,
think?
well, there are some preliminary studies looking into this. There are case series, so that they have tried, as you say, to then half it or maybe use 1/4. Of course, these are mostly BMD and BDM case series. We
Yeah,
have
not fracture.
no
Yeah.
fracture. It seems to be one possible way, what you're saying.
Because I have
yeah.
often wondered if in the future we will end up giving sort of higher dose denosumab for 5-8 years and then giving a lower dose for a year or two and then going back up to the high dose, and if perhaps that is the way that we will end up
Yeah.
treating these things rather than using zoledronate.
Yes, yes.
And, you know, there's a structure in bringing people into maybe hospital or clinics to give them the drip, and there's problems, as you say, patients with renal failure. So maybe we will end up moving away from the bisphosphonate and just altering the dose of the denosumab.
Yeah, there are ideas and studies beginning along those lines, yes.
I think some of our listeners would be keen to know a bit more about the discussions that you have with your patients around the medications and when you stop them. I guess it might be useful for people who are going to have similar conversations with their own doctors. What kind of questions do the patients have for you, and what kind of messages do you give them?
I think, first of all, it's important to explain maybe this notion of osteoporosis to the patients per se. Because, of course, if patients have not experienced fractures and it is an opportunistic finding, let's say so, in a DEXA, they don't really understand these T-scores and what's like the relation to a risk for fracture and why would they be willing to start on a prophylactic treatment. So I think this is one major issue which you have to talk to really at the first patient's visit to make them understand this. Then what they want, of course, to ask. I have a lot of patients now which are more informed also through the internet, and they do even know this differentiation and classification between bone resorptives and also osteoanabolics. So they, of course, if they are very eager to do the best for themselves, they ask right from the beginning, can I get an osteoanabolic? I mean, this is also a question that I have. So you also have to explain the indications, also the differentiation. And then, of course, a lot goes into side effects and rare side effects to try to relativize things, because you also have the extra pedantic, if I might say so, or acribic patients that go through all the information that you can find in the drag sheets and everything that has been described once. And you have also, of course, to explain to them that there is no causal or no plausible causal relationship between this side effect. And so I think usually my first patient visit with a patient that I don't know takes about an hour, because I try to be to be really thorough.
I think it's so important to get the information in right at the start, isn't it? We've all seen patients who have been prescribed a bisphosphonate for 8 years, and when you talk to them, you realise they haven't been taking it correctly. They've been taking it with their evening meal, and they really may as well not have been taking it. And if someone spent 10 minutes 8 years ago explaining the thing properly, not even an hour, even 10 minutes, then it would have made such a difference in the long term.
I agree.
Do you feel as well everyone needs to be on message, because you and I, maybe as osteoporosis specialists, understand this and try to explain it to the patient in the clinic, and we're all on message, and then maybe the patient goes to a dentist who maybe isn't just as up to date, and the dentist says, oh, bisphosphonate, that's terrible, your teeth will rot, and it undoes all the... So we need everyone, we need the pharmacist and the dentist and the GP and everyone to be giving the most up-to-date advice at the same time.
Definitely, and especially with the dentists and anti-resorptives, it's a really big issue. So what we have implemented, it is so that we write patient letters for the GPs, and we also have a special paragraph which is addressed to the dentist, and it has to do with future dental procedures, what should be taken into account, what about the interval between, for example, denosumab and the dental procedure, if you should do, of course, antibiotics during the time, that you should also have regular checks. So
what are you advising with denosumab for dental work at the moment? Because lots of people will want to hear this.
So, of course, if it is possible, and it is an elective dental procedure, and it is something that you can do before, you can perform before starting on denosumab, it is advisable to do so. If it is something which also is not an emergency and during treatment with denosumab, it would be, of course, better to, if you can plan it, to do it at around, say, month 5 or month 4.5 after the last injection of denosumab, in order to have like the most duration since the last shot. But of course, you should also let them know that if they have like a dental abscess, it's not like that they should postpone having treatment of an emergent dental procedure because of denosumab. This would not make any sense at all.
I think if you have quite high-risk patients, the risks of delaying denosumab are much higher probably than the risks of having treatment-related osteonecrosis.
And of course, it is also the risk profile that they bring with themselves independently of denosumab, if they take corticoids, if they're immune suppressed, if they smoke, if they have diabetes. So there are a lot of risk factors also to consider.
It sounds like hard conversations in many ways. A lot of information, a lot of explanation, and maybe having to challenge some preconceived ideas that people come with. How do you feel having that conversation again and again and again with every patient?
I think it's our, if I might say so, our duty as MDs, and also it helps very much to have a relationship where the patient think that they can trust you, because it's not a good thing, I think, if you try not to mention subjects which, as I said, are in everyday social media, like osteonecrosis of the jaw or the no-smoke discontinuation and rebound phenomenon. I practice in Germany, and I have like the patients which know the word rebound and say it in English, because yes. So it's definitely something that it is on people's mind, and I think it's very important to address it right from the beginning. Yes.
Do you think we have all these very effective drugs now, which sometimes, I don't just mean for osteoporosis, across medicine in general, which means the doctor-patient relationship, the caring attitude, doesn't almost have to be as important. It should be important, but we were talking before we started about ancient Greece. So if you go thousands of years ago to the first doctors, they had no drugs that worked. All they had was their caring attitude, the patient relationship. And then we developed these drugs that worked. And, penicillin will kill infection, whether you're nice to the patient or not.
Yes.
And we therefore lose some of that patient relationship because we're so focused on how well the drugs work. But actually then we overlook the fact that unless you explain the drugs and build up trust and have that caring attitude, which goes way back thousands of years into what a doctor's all about, then you do lose some of the effectiveness of the drugs, because the drugs are only good enough if they actually get into the patient's body.
I agree. It's very, very important. And also another aspect, of course, is also the non-medicinal, non-drug treatment for osteoporosis. It has to do with dietary aspects, or with exercise, or with a healthy lifestyle. So this is also a very important aspect, which I also try. I try also to convey the message that it's not like that we're giving you now the super drug and now just be a coach potato and don't do anything.
It's not just what Richie teaches us from the lab, it's what Hippocrates taught us thousands of years ago.
Yes.
You mentioned other things other than just drugs and other lifestyle measures. So we've got to ask you a little, if you had to recommend a sport for patients, which would you recommend? And I have a strong suspicion what you're going to say here.
You know about tennis. You
Okay.
you can play tennis at every age, I think, of your life, like starting from a very maybe young age where you're more competitive, you play singles, and then as you move along maybe into life, you can switch into doubles. And where I play, of course, in my tennis club, I also get the opportunity to see this. And another aspect which really makes me happy that we have this is that we have a program for wheelchair tennis. Mm-hmm. So this is also very beautiful to see young children, how they get introduced to this wonderful sport, and they have fun playing it.
I've played a lot of tennis. You're preaching to the converted here. What is it about tennis then? It's the jumping about, is it? What is it that makes tennis good for osteoporosis?
Well, I think there's a lot to do also with balance, which is also very important. There is, of course, a lot of running if you do it like in a
high energetically,
right? Yeah. So it has to do also with the particular osteoporosis patient. I wouldn't recommend it to a very frail patient, which I think that they are at a very high risk for fractures. But I think it's something like it keeps you. It's outdoors normally. It keeps you going and in movement, and it has also a lot of coordination with also, which is for maybe preventing falls.
So it's not just the resistance training aspect of it. It's the coordination and the stability and the balance of it. Yeah, and it's good fun as well.
But I have to say about tennis, I'm not objective at all.
Who's your favorite tennis player?
Oh, it's between two. It's Roger Federer and Sir Andy Murray.
And Sir Andy Murray. Good answer. Yeah.
Well, Rog, Andy, if you're listening, get in touch. We can switch emails. Maybe you won't get osteoporosis later in life. Yeah. And for the listeners, it sounds like tennis is the holistic approach to avoiding fractures.
Indeed.
Thank you very much for joining us today.
Thank
Elena.
you so much,
It's
David.
been great fun.
And
Thank you
Richie.
very much.
I really enjoyed it. Thank you.
That's lovely.
Listeners, it was a lot of fun talking to Elena. We had a good laugh. David, what were your takeaways?
Apart from Elena's enthusiasm about tennis and about the health benefits of tennis, with which I agreed. Do you know, we often say the takeaway is we need more research, but I think probably my single takeaway from this is the need for a large, carefully designed study that I can give people proper scientifically backed advice on what to do when they've been on osteoporosis drugs for a long time, but very specifically denosumab for a long time. You know, you get up to maybe 8, 10 years on the drug. The options are you can simply stop the drug, and we know that that's not a good idea, that you will lose bone and there'll be an increased risk of fracture. You could switch to intravenous bisphosphonate. You could reduce the dose of the drug. You could reduce the frequency of the drug, or you could simply stay on the drug. You could switch to an alternative. You know, the study almost sort of designs itself, and I like to be able to give patients proper scientifically backed evidence, and at the moment we really don't have convincing evidence of what to do. And I think Elena very carefully sort of set out almost the protocol of how what that sort of study would look like. And I do think it's one, each individual center could do a study with 100 patients. I do think it's one that really a large international study would be the best option here. We could all take part in, and we could then give patients really good, solid advice on what's best to do. And from a more maybe basic science point of view, I know you love talking about mechanisms of osteoclast activation and so on. What did you take out of our chat?
I think my first takeaway is that patients are really good researchers. Both Elena and yourself talked about the questions that you get from patients and the detail that they want to go into, what great knowledge they can come to the consultations with. And I think that's really, really wonderful. My other takeaway really is about the role that education of patients plays in building trusts, supporting patients to take the treatments that they're offered and then stick with those treatments. When we were doing the interview and Elena was talking about how long she spends talking to the patients, explaining to them what osteoporosis is, what the treatments are, what the side effects are, and answering a lot of detailed questions, my first thought as an educationalist is, well, is there a way that you could package that information for people to take away so that you don't have to keep having that conversation all of the time? I hadn't really appreciated, and I got this from Elena's really eloquent and enthusiastic and heartwarming answers, that actually having those conversations is as much about building trust with the patient as about actually informing the patient. And I hadn't realized that. I guess it's really important that those conversations get had again and again and again. And I suppose a third takeaway is that we talked to Elena quite a bit about individualized medicine. Elena was explaining how when she treats patients, especially with denosumab, that she tries to take an individualized approach to the patients. But actually, the clinical trials that collected the data, the evidence that support the use of the medicine, were done at a population level on large numbers of people. And it makes me wonder about how it is that we can go from large-scale clinical trial data on a medicine through to individualized patient care. And I think maybe in the future we need to get a guest on who can talk to us about that, and how the clinical trials we have around osteoporosis and the medicines for osteoporosis can actually help inform clinicians about how to go about individualized care for patients. I think that would be really interesting.
Yeah, I think that's an interesting point. When a new drug comes along, there are lots of studies looking at the drug. Many of those sponsored or organized even by the pharma company that's developing the drug. And that's quite understandable because you have to prove that the drug works and prove that it's effective. Where there are fewer studies are down the line, and that is how to get off the drug again further down the line. There's probably less incentive for the pharma company to sponsor that drug, or to sponsor that trial, I should say. The drug is often off license at that stage, so there's really very little incentive. And I think that's where it falls more to the osteoporosis community, to the science community, and to the medical community, to organize those trials. And to make sure that those trials are relevant to the individual patient. And yes, I know it sounded as if we were getting quite sort of philosophical and talking about, doctors over thousands of years, but I do think that's very true. It's always amazed me in some ways how medicine became a profession and a reasonably respected profession over thousands of years when really there were very few effective medicines. And that must have been, it was based largely on the fact that doctors were, I presume, caring people and honest people and trustworthy people. And it's really important now that we're in the age of exciting, scientifically designed biological medicines, that we retain that traditional professional approach, that caring approach, that honesty and integrity, because it's still absolutely vital to what we do to get the patient to take the medicine. And then actually, if you've been taking a medicine for years and it's been working well, to trust the doctor when the doctor says to you, you may actually need to stop that medicine again. And that's not something can be done by just saying to someone, watch a video or read this handout. It still, I think, is based largely on a lot of face-to-face interaction and getting to know the patient and getting to remember the name of their spouse or their pet, and just little things like that make a difference. And as long as that's part of medicine, then it's something I will still enjoy doing.
Oh, I think that's a nice place to leave it today. Thank you for joining us, listeners. Bye-bye.
Bye now.